Thank you, Tom. Thanks for the nice introduction. Thanks, Susan, for the great talk yesterday. Katie and Deb for all your help, and all of you on this remote screen. And as Tom said, please feel free to interrupt. I will not be watching the chat, but Tom and Susan will, and we'll jump in if issues come up. I want to first start to tell you a little bit about how I got introduced to DMCs. There's two parts to the story. The first was in the late 70s. I was living in Manhattan, and my very good friend Judy Goldberg called me up and said, this really interesting committee I want you to be on. It's going to be looking at the safety of an experimental treatment. It's intracoronary thrombolysis. And this committee is going to be, it's going to be small. You're going to look at the data as it's coming in. It's been really exciting. And I said, well, that sounds like a good idea. That sounds fun. And so the PI put in a grant proposal, and my name was on the list of this data safety monitoring committee. And it went to the grant proposal, and Paul Meyer was at the review committee at NHLBI. Paul Meyer of Kaplan Meyer was on the committee, and he said, who is this? Get her off. She's too inexperienced. We need somebody experienced. So that was my first experience with the data monitoring committee. The second one was in 1983. And I have to say that over the years, I used to tease Paul about that, and he was apologetic, but I was young and inexperienced. He was correct. So in 1983, I came on as the branch chief of the biostatistics research branch at NHLBI. And Kent Bailey and Gordon Land, who were in the branch at the time, came up to me almost the first day and said, you're really lucky because as the branch chief, you can go to any DSMB you want to go to. And they advised me, go to them all. They're really fascinating and you'll learn a lot. And so that was my 7 years at NHLBI. I attended every DSMB I could do. Since then, I've been involved in DMCs. And you'll see, I'm going to be switching, as Susan did, I'm going to be switching the language from DMCs to DSMBs, to sometimes DSMCs, but they're all the same. I've been involved as a member, sometimes as a chair, sometimes not as a chair. I've been involved as the representative of the sponsor when I was at NIH and when I was at the VA, and sometimes when I'm consulting for industry, and as the independent statistical reporting group, as the group that does that. So I've been involved in three sides of the table. And I want to first of all say that these slides are plagiarized. And one of the problems with plagiarism, the way I do, I can't tell which piece is mine and which piece is somebody else's because we've all worked together so much. But these are stolen from or modified from slides that Kevin Burr from the University of Wisconsin has prepared, Matt Downs and Janelle Rohrer from our company, and Jean Rouleau at the University of Montreal. And here's my justifications for plagiarism. Only be sure always to call it, please, research. A lot of what I'm going to be saying is reflected by the paper that the group of us wrote, Kevin and Robin Beckhofer from Wisconsin, and Matt, Janelle, and I from Statistics Collaborative. We share the same views of how DSMBs and what I'm calling ISRGs, Independent Statistical Research Reporting Groups, should be reporting. What we're going to be doing, the first part before break, will be an introduction to the reports and a 30-minute break for those of us on the East Coast to have some lunch. Those of you on the West Coast can do whatever you want. And then part two is about the look and feel of the report. So here is, what is the role of the ISRG, or it's also called SDAC, the statistical data. What's the A, Tom? Something.
Analysis
Center, thank you. And as a plagiarizer, the first slide I'm going to plagiarize is Susan's. What Susan introduced is a slide that talked about why should there be interim monitoring of trial data. And she identified 4 main reasons. 1, to identify any safety problem quickly, and there the quickly is really important. To identify problems with trial conduct, accrual that's too slow, baseline characteristics that are not what you want, and then problems with the trial itself, dropouts, noncompliance, protocol deviations. To evaluate continued feasibility of the trial as presently designed, and then she put in parens to determine if the trial objectives have already been met. And she commented, and I was amused and totally agree with the comment, that this is what we as statisticians often think the most important thing is, how to do interim analysis for efficacy. But it's really safety, trial conduct, and feasibility that are the main issues. And what I'm going to try to do is talk about how you can prepare, how a report should be prepared in order to address those issues. So I want to start with talking about 4 ways of reporting about a clinical trial. Now you only see 1, 2, 3. There is a 4, I promise. I know how to count. The first is the primary paper. So you read a paper that summarizes the study. It has fewer than 4,000 words. It'll have 2 to 4 tables. It might have a couple of graphs. And so it's very compact. So you have a study that could be hundreds of people or thousands of people or tens of people. It could have taken 4 months or 4 years or 10 years. But the report is very small. The audience is a long audience, a big audience, thousands of practicing physicians, payers, and so forth. And then the second kind of paper are other papers. Each one ranges, I don't know, 2,000 to 6,000 words. And the audience of that, it's a stuff that couldn't get into the main paper. The audience are people interested in the product, or the class of product, the mechanism of action, a subgroup, some specific piece. And then there's the clinical study report. That's the report that goes to the regulators and says, okay, we're going to summarize we're going to summarize what happened in the paper. And this is now 50,000 words, 100,000 words, oodles of tables, figures, and listings. It goes on and on, pages and pages and pages. And the audience is just a few handfuls of regulators. So the little tiny paper has thousands of people, and the big, huge report has a couple of handfuls of regulators. So what's the 4th one? The report we're talking today is the Data Monitoring Committee report. It should be, I think, between 20 and 200 pages. There should be lots, not oodles, lots of tables, figures, and listings. And lots means enough to get the message across, but not so much that the reader gets lost in the tables. And I believe, as Susan expressed yesterday, there should be explanatory text. And we'll get back to that later because there are people who think that's not correct. The audience is now 3 to 10 people, maybe 12 in a great big DMC, but hardly ever any more than that. And the regulators are sometimes interested after the trial is over. So it should be a small report, very focused, addressed at a very specific audience.
Just a brief interruption or added, Jen, it's such an important point, just from experience. So often I'll see a report that is much longer than that, in particular because it's just generating huge numbers of listings.
Yes, which is why I wrote the ideal. There are things that are I've been involved in 25,000 pages to a DMC. Okay, So what are the purposes of these summaries? The primary paper is kind of a guide for physicians' practice. Should they use, is there enough information enough credible information and convincing information to use this product, or maybe to stop using a product that they've already used, or not to use it, but something to guide practice. The other papers are to tell you further information about the trial, sometimes mechanisms, so biological arguments, sometimes excuses. Well, we did the paper, the p-value was 0.27, but it really showed benefit. We just didn't look at the right pieces. So sometimes those papers are there. And then insights for further research, so all kinds of stuff. The clinical study report is the summary for regulators in deciding whether to approve the product and how to label it. So that's a really, they have all the data now in the report, and they actually have, the FDA has the actual data. The other regulators, like the regulators in Europe and Japan and Canada you don't get the data, but the FDA has both the report and all the data, and then they have to make decisions about approval and labeling. But the Model Data Monitoring Committee report is a tool for making recommendations about the ongoing trial. And I'm actually want to stress 3 words here: tool, recommendations, and ongoing. The tool is, this is the only thing usually that the DMC has, so it better be an effective tool. The word recommendations, the DMC doesn't make decisions, it doesn't take actions, it makes recommendations. And ongoing is really important. It's not the end of the trial. It's not the data at the end that says, now we know what happened. It's what should we do with, how should we recommend the trial? What should we recommend about the trial as it is ongoing? Okay, so what I'm assuming that those of you on Zoom, some of you are current or future members of DMCs. There are sponsor staff responsible for selecting the ISRG, the Independent Statistical Reporting Group, and for selecting data monitoring committee meetings. They're members of the Data Monitoring Committee Reporting Center, the ISRG, and I'm thinking of a phase 2B or 3 trial. I'm not thinking about an early phase trial. What I say may be relevant for them, but I don't think in those terms, so mine are trials that are phase 2B or 3. And you will operate, if you're a member of this reporting center, you're going to have to operate independently, and I put that in quotes. We'll get to what I mean by independent later, of trial sponsors in the data and trial management CROs, the contract research organizations. The reason I put quotes around independent is you're paid by them. And so is the DMC paid by it. So it's a special kind of independence where you're independent, but you do get paid by them. And in the reporting center, you need to have broad experience. Well, it depends. If you're a reporting center that specifically reports for DMCs for, say, ophthalmology, you don't need broad experience in many disease areas. If you're a group that works with many disease areas, then you better have broad experience and not be bashful about asking questions if you don't know. You'll be involved with many different sponsors who have very different views of what a DMC should be. And you'll be involved with many different DMC's members who will have very different views of what they should be doing and about what you should be doing. And you'll have likely to see trials of many types and many sizes. So you need to be flexible. So what you knew, yes, before you came yesterday and either learned yesterday or was Susan emphasized, I'm assuming you're aware of the purpose and importance of data monitoring committees. Again, that the data monitoring committee needs a tool for making recommendations, that the members are busy. We'll get to the busyness in a second. And that you all agree that DMCs should be, quote, independent. And I want to remind you of the structure of a trial. Here is the sponsor. This is the group that is ultimately responsible for the trial. It may be a company, it may be the NIH, it may be the VA, it's somebody whose trial it is. And that sponsor reports to regulatory agencies. There is also a steering committee. The steering committee may be a subset of the sponsor. It may be completely separate from the sponsor, but reporting to the sponsor, or it may be a group. So this may be an academic group. It may be a combination of an academic group and a sponsor group. The Independent Data Monitoring Committee, here I'm using independent, reports to the steering committee. Sometimes it reports to the sponsor. So it depends on how it's established. And then there's the Independent Statistical Reporting Group, who is paid for by the sponsor, but reports to the IDMC and is responsible to and should be responsive to the IDMC. In addition, there is the group that is doing the trial. There's the Data Monitoring Center, Management Center. It may be the sponsor, it may be a contract research organization, but it's actually dealing with the data. There are the central labs, there are all the clinical centers, there's the institutional review boards, and way at the bottom, but incredibly important because they're the most important piece of these studies, are the participants themselves. So as you're thinking about what this group does and this group does, remember that they're in a sense on the side as the study is going on. But their role is to look to see how is the study going on and are there changes that they think should be made. All right, I've used the word independence about 5 times. Sometimes we say independent DMC, there's an I there. Sometimes, and here's the Independent Statistical Reporting Group, but it's fake independence because the sponsor pays the members and the ISRG. So the members and the ISRG must act as if they're independent. They must be intellectually independent. They must behave the way they would if there were no money involved. They must not feel in any way tied to the demands of the group paying them. So this is a really, really important point, and that many sponsors don't appreciate that the group to which the ISRG, the reporting group, the group to whom they are responsible to, is the Data Monitoring Committee, not the sponsor. Okay, so what is the report to the Data Monitoring Committee? It's the report that's reviewed during the closed session of the meeting. So where the Data Monitoring Committee and the Independent Statistical Reporting Group is present, and not the sponsor and not the executive committee. It's the most important source of information for the DMC to be making its recommendations. It needs to have enough information so the DMC understands the progress of the trial. How is it happening? How is it going on? And it has to provide data that is clear enough and comprehensive enough that the DMC can make intelligent recommendations. Okay, that sounds pretty simple, but the problem is that many reports are long. I mean, I referred to 25,000 pages. Tom referred to huge reports, often unclear, often unfocused, full of errors, inconsistencies, and bad statistics. And I'm going to give you some examples just so you don't think, oh, she's making that up. The question that I often ask myself when I see one of these reports is why? Are the statisticians who are preparing these poorly trained? They don't look poorly trained if you look at where they went to school. Is there no careful review of these reports? Are they driven by dollars and not by science? So these are the questions that I ask myself when I'm confronted with a report that I know the person preparing it couldn't have been proud of it. And I hope I'm going to give you some useful tips on how to prepare reports and how to negotiate with sponsors to allow useful reports. So first, we're going to talk about the organizational meeting, which Susan talked about before, yesterday. Ideally, the DMC meets before recruitment starts. And I always used to say it's best if it's in person, because during these horrible times, it can't be, so have to be some sort of Zoom-like report. During that meeting, there's a discussion and approval of the charter, review of the study design, and as we talked about yesterday, this is the last opportunity for the DMC to comment on the study design before it's contaminated by access to unblinded data. So if there are problems that it sees with the study design, this is the time to say it. It should have, the model informed consent should be there. The DMC should be always thinking about when it's seeing safety concerns. Is this something that the participants were told about, or is it something that's new? There should be a discussion of the plan for interim analyses, if there are going to be one. And it is the obligation of the reporting group to explain the interim analysis, what it is, how it's going to happen, what the statistical consequences are, or the statistical justifications. Often that's not done very well. And it's unfortunate because decisions and recommendations that have to be made are made by a lot of physicians on the committee who don't really know what these the ways of doing interim analysis are and what they mean and what the consequence is. Often the case report forms are often available, so the DMC knows what is actually being collected, and the investigator brochure is available. So the investigators know, the DMC members know what the investigators have been told. And this should be a meeting with discussion of potential sticking points while everybody is naive to interim results. They're naive to interim results because there are none yet. At the org meeting, there's often a discussion about access to efficacy. And Susan talked about this yesterday, and we talked about several of us jumped in. Sometimes the efficacy endpoint is also a safety endpoint, for example, death, progression-free survival, visual acuity in ophthalmology studies. And as we discussed yesterday, data monitoring committees often wish to assess potential risk and benefit if they see a safety signal. So my own view is very consistent with what you heard from Susan and others yesterday, that yes, there should be access to efficacy data. The sponsor is often concerned that to maintain control of information about treatment effect during the trial. And so a lot of sponsors don't like to show efficacy data. And regulators may require statistical penalties for what are called safety looks. So here are some compromises. So my view is that DMCs should have access to efficacy data, but in order to satisfy the concerns of others, one approach is that the efficacy data are presented only upon request, and then you document the look in the summary notes. Then another thing that I've seen done, which seems really silly to me, is you present a variant of the efficacy endpoint. Supposing the efficacy endpoint is time to death. Don't present time to death. Present proportion of deaths. Or present the survival curves, but don't put the p-value in. Those have seemed to me a little silly, but I've seen that done. And the other thing that I have recommended, and I know people think this is silly, is to give a tiny statistical penalty assigned to each look. And that way you can deal with your type 1 error rate, and it doesn't affect the p-value at the end. But the point is, however you do this, whatever you do, my view, and I say our view because I know it's Susan's and Tom's as well, that the DMC should have access to efficacy data. The other thing that is often discussed at the org meeting is stale data. There's a tension between how current the data are and how accurate they'll be. Sponsors don't like to give dirty data. And so they'll say, we will only give data that are clean. The best way, well, a way to aggravate a data monitoring committee is to show them unacceptably stale data. And I can see Tom's face right now because I know this is not something he likes at all. So the discussion ought to devolve into, we, the DMC, is comfortable with data that are somewhat dirty, but we want the data to be very recent, and we want the reporting group to be able to deal in an intelligent way with dirty data. So how do you do that? One of the things that the reporting group has to do is program defensively, so that as the programs notice data that clearly are wrong, do something with them, get rid of them, so don't program the way you program at the end of a study, and we'll get back to that later. And one approach is to have 2 tiers of data. For the read ahead report, that can be clean data, baseline data, the data that are that don't change much over time. If you want that to be stale and clean, that's probably okay. But the data that are really important, the deaths, serious adverse events, the efficacy events, if this is going to be an interim analysis, they better be refreshed just before the report and perhaps updated at the meeting or a day before the meeting. And often, now this is now a message to those of you who are on DMCs or will be on DMCs. Often sponsors won't bring this up unprompted, that you'll only learn that the data are stale after you have the first or second meeting. So it's important for data monitoring committee members, so this is, I'm addressing it to you current or potential members, make sure you speak to the sponsor at that primary meeting, at the organizational meeting, and find out how they're going to deal with how current the data are going to be that you are going to see. The other issue that often comes up in the organizational meeting is masking. Again, this is a topic that Susan brought up yesterday. And it's really good to have, my view is not to put the actual name of the drug in the report, because people, if you're, in the old days when we could travel to meetings and people would read the report on the plane, somebody next to you could peek over and look. They shouldn't, you shouldn't hold your report like that. But nonetheless, having the names there has the greater potential for it being seen by somebody who shouldn't see it. We don't like to use A and B. The person who taught me this was George Wittes, who's a cardiologist in Calgary. And George said, if you give it labels like that are words that I can relate to, I'm not going to forget which group it is. If you call it A and B, I can't remember. So we tend to use, for expedition, Matt Downs used Lewis and Clark. And then everybody refers to them as Lewis, and they remember which is the treatment and which is the control. And then there are different philosophies. Some people say, and I'm in that some people camp, that the data monitoring committee should know the identity of the treatment that corresponds to labels, and others say they should only learn upon the identity upon request. As Tom pointed out yesterday, one of the things that people do, if you have a report that doesn't tell you which group is which, the first thing you do is you open the report. Let's say it's a LDL lowering report. The first thing you do is you open the table that shows LDL, and you see which group lowered the LDL, and now you know which group is which. It's very unusual that you can't figure out from lab data or from adverse events data which group is which. So this is often an argument that doesn't really make any difference. So, and in fact, we've had sponsors say to us, what you should do is form, to maximize the objectivity of the data monitoring committee, the data monitoring committee should review the data with two sets of opinions, one assuming group A and one assuming group B is active. And we've done reports in our youth. I don't do this anymore, but because I used to be more obedient than I am. One of the advantages of getting old is you can be disobedient more. That even for data on efficacy, we used to, at the request of the sponsors and no objection from the DMC, present, if A is the treatment and B is the control, here's the hazard ratio. If B is the treatment and A is the control, here is the hazard ratio. So it makes for a lot of work, and it's unnecessary, and it's really a pain in the neck for the poor DMC. The other thing that's happened sometimes is that companies will send a sealed envelope to the chair to open only if needed. Now, for those of you who are or thinking of being a reporting group, can you imagine writing a report and not knowing for sure which is a treated group? Because only the chair knows, and the chair is told, don't tell the reporting group. This is a sure way to increase the probability of an incompetent report. Or another approach is the reporting statistician is given the envelope, and then they're allowed to tell the DMC only if the DMC asks. To me, this is all a charade. We should get rid of it. We should be open but completely confidential. And so This requires a huge amount of trust, and that's the word you heard both from Susan and Tom yesterday. The sponsor needs to trust the DMC and the reporting statistician implicitly. If you do this way that you're only unblinded when you ask to, then the minutes document that. Okay, now let's talk about, if you're a DMC member, what do you want to see? What DMC? That second want, what is want and need to see. So first of all, DMCs come from very different organizations. The organizations have different goals. They're academic institutions, they're national funding institutions. The academic institutions often interested in the mechanism, not always, but often. The national funding institutes often interested in issues related to public health, very often, well, I shouldn't say very often with treatments already available. Large multinational companies who have many different drugs, no one of which determines the fate of the company, but some are more important than others. And then biotechs that have maybe one product, and this product is really important to the company's life. The reporting statistician and the report try to focus the discussion. The discussion may be about the trial conduct. Maybe there's issues, regional issues that are different. There may be emerging safety concerns. There may be a balance of observed risk and potential benefit. And the reporting statistician and the report should be formed in such a way that you can address these. One of the jobs of the reporting statistician very often is to bring the DMC back to terms of reference and to the informed consent. Because remember, who are these members of the DMC? They're often really experienced people who are very interested in the disease under study, very interested in the drug under study, and they're going to want to see all kinds of things about science that are really important, but not relevant to what they have to do. And then there's the informed consent. It's very important that the DMC knows what the participants have been told. So when they're making recommendations, it's consistent with what the participants have or have not been told. And the other thing that the reporting statisticians got to remember is that the data monitoring, the DMC members, they don't work on the trial every day. The sponsor tends to forget that their life is often every day they're working on this trial. So the report should supply what the members need. The report should have a trial summary, because the DMC members, if it meets every 6 months or every year, it's going to forget. It should have the charter there, so it remembers what they were supposed to do. It should have helpful explanations. For example, in this study, is a hemorrhagic stroke called a cardiovascular event? Is it called a bleeding event? Is it called both? So things that are study specific, the reporting statistician should inform the committee on the report. There should be tables summarizing the primary and secondary endpoints that they saw in the past to remind the DMC what it was it was thinking 6 months ago or a year ago, and the SAEs. You may, and Susan talked about this, combine endpoints and specific SAEs so that you can make a coherent story. Now, there is an exception to all this. I'm on a committee now, I'm on the recovery DSMB, which is the Oxford study that's looking at various treatments for COVID-19. We meet very regularly, every 2 weeks, except when we meet more often. We don't need all this stuff because we remember it. So again, how much you produce for a committee depends on how involved and how frequently the committee meets. They need to know, is the trial integrity being preserved? Will the primary hypothesis be tested adequately? Are the participants safe? And has the trial already shown convincing evidence of benefit? So this is very similar to what Susan described. What are the kinds of questions that the report should be asking about trial integrity? Is the blinding adequate? So some sponsors use the same organization to capture the data, to prepare the final report and report to the DMC. And they define firewall statistician to work with the DMC. The DMC better understand whether the firewalls are good enough. In some trials, people within the same clinical group are blinded and others are unblinded. DMC better know that. The other thing the DMC should be aware of, do the data look credible? And we'll get to what does that mean? What does it mean to look credible? Is adherence to the intervention and the protocol, is it acceptable? You should see adherence over time, because if adherence is really terrible, the study probably may not be able to answer the question it addresses. And there should be a sense of the major protocol deviations, not the little ones, but the big ones that may call into question the credibility of the trial. For outcome trials, for example, if you're looking at mortality or heart attacks or progression-free survival or 3-line loss of vision, are the event rates close enough to the event rates predicted in the study? If the study has an adjudication committee, is the adjudication occurring rapidly enough for the DMC to make informed recommendations? How closely do the investigator and the adjudication committee agree? Does the agreement and the speed differ importantly by site? Do you have some sites where the agreement is way off? Do you have some sites where the agreement is too good? Does it differ importantly by severity of disease? Often, the more complex the case, not surprisingly, the higher the probability of the investigator and the adjudication not agreeing. For trials with continuous outcomes, are the variances close to what was expected? And is the dropout rate low enough to allow valid analysis? Are the participants safe? The data on safety has got to be presented in an understandable form. Jean Rouleau said, we shouldn't have to look for a needle in a haystack. Start with the SAEs, then the AEs. You may include drug-related, you may not. Lots of experienced DMCs say we don't pay any attention to drug relationship. We look at the 2 treatment groups and we see whether the rates are different. That's what defines relationship. We like to use color to identify potential areas of interest. So the DMC, as it's looking at its report, can focus on something. Now, there will be some DMC members that will object to that they will say, you are leading us on, don't do that. And when that happens, you don't do the color. You want to combine related SAEs, like Susan described yesterday. You should be thinking about the mechanism of action of the drug. You should think about potential areas of adverse events related to the drug's mechanism of action and structure. For example, if you have very low lipids, you might produce mental or neurological complications. So the reporting statistician should be looking at that. If you have interventions that use viruses as a vector, might cause inflammatory reactions. You should be looking at inflammatory reactions. As the reporting statistician, you may not know all this stuff. So take advantage of the expertise on the DMC. Call the chair in the DMC and say, what should we be looking at? Or ask at the meetings, what should we be looking at? And remain flexible. As the study is ongoing, you're learning more and more. The report will change. Don't lock the report into the same presentation at each meeting. lab values. We as statisticians are often interested in changes in means and medians. Docs are interested mainly in extreme values. Are they too high, like liver enzymes? Are they too low, like white blood cells and platelet counts? So it's important to show both the central values and the outliers. So we like to use box plots, but figure out a way to show outliers. Often the outliers are incorrect because people use the wrong units. So you've got outliers that are just completely wrong. Sometimes the numbers are wrong because they're wrong. So we've had potassiums of 11. You know that that person would be dead if they had a potassium of 11, so you can delete it. But some values can get very large and you shouldn't delete it. So let's talk about that. And for Hy's law, for liver toxicity, a whole different, you need to show Hy's law. So here's—
Janet, this is such a great point for QTC, for example, you know, where we're often shown means. It's really many times what we're really interested for risks of sudden death and torsade, et cetera, is are you above 500 milliseconds or do you have a 60-second millisecond increase? So I've often said the same thing you're saying here. Let's think through what are the clinically relevant lab changes, not just generically present a lot of mean changes.
Yeah. Yes, which means don't just have one program go on all the labs do the same thing. So let me show you my favorite, my Bambi and Godzilla plot. Now, for those of you who don't know the reference, just look up Bambi and Godzilla, and you will see a video. It was a movie of somebody, a student who won an award for the best. It's Bambi running along the grass and Godzilla putting his foot down and squashing Bambi. This to me is a Bambi and Godzilla plot. You see, oh, and unfortunately, this 6537, that's not the value, that's the sample size, and I didn't know how to delete it. So the value is around 4,000. So you look at this and you say, I don't know. I mean, I would look at it and say, I don't know whether this number is real or not. I know I can't see anything here. What should I do? Well, first thing to do is to look up and find out whether this number, 4,782 international units, could be true. So you look it up and you discover, yep. Okay, so if you look up the number in whatever source you look up, you'll see the range in normals is about 220 to 200 international. But if you have rhabdo, it can go to 20,000. So this is not like a potassium of 11, which would mean the person is dead, or could never have gotten there. This could be real. And the fact that there are two here that are so big suggests that maybe these are real. So what do? You could show, here's the Bambi and Godzilla plot, and here's the plot that looks at the mean and the median, the box plot, excluding. So people know that. And you should also, for these three numbers, go look and see what other adverse events they had. What else happened to these patients? Is this something to worry about or not? And if you don't know, the DMC members will tell you, they'll ask. The report might define subgroups of extra risk. So you're doing a study and you're looking at the data, at the adverse events, and people are worrying, gee, you're seeing some renal complications or some pulmonary complications. The DMC might say, let's look at these patients. Who are they? Should there be some people that we should say to the sponsor, we don't think these people should be entering the trial. So those are not subgroups for benefit, but subgroups that are at elevated risk. If the trial has statistical stopping guidelines, supply the data monitor committee with the charter, remind members when the interim analyses are planned, remind them what the guidelines are, and explain what the guidelines mean, and explain in language that the physicians can understand. and show pictures of what kind of things might be leading to crossing a boundary and what might not. Supply a table that summarizes the primary and secondary outcomes, because it's very possible that a committee, if you cross a pre-specified guidelines in the primary and the secondaries aren't showing anything, the DMC may say, we don't want to stop. We're not convinced enough. And for outcome trials, show Kaplan-Meier curves. If you're involved with a study that has adjudication, present the data from the investigator report, the adjudicated, and the best available, where best available is adjudicated if adjudicated, and for those not yet adjudicated, investigator reported, and show crosstabs. How many of the MIs reported by the investigator turned out to be MIs by the adjudicator, and so forth. Okay, with that as the sort of what the DMC members need to see, how to repair them. So the guiding principles are, remember, they're not clinical study reports. They need to be comprehensive but comprehensible. They must facilitate efficient review. The report structure must be clear, and the analyses must be interpretable. That may all sound very easy. It's not so easy. And the reports must be responsive to reasonable DMC requests. If your DMC is asking for something and it's reasonable, you should do it.
Janet?
Yes.
There's a question.
Oh.
Can you clarify what you mean by adjudicated data?
Oh, sorry. Yes. So you have an adjudication committee is adjudicated data are data that have gone to a committee which decides whether the endpoint that has been reported is an endpoint. So for example, a person is in a trial and the investigator says this person had a heart attack. So it's called heart attack. Then all the information about that event goes to a committee. The committee looks at all the information, the clinical study, the clinical reports and the case report forms and the EKGs, everything you can get. And they say, yep, this was a heart attack, or nope, this wasn't a heart attack. So it's the data that has been scrubbed, made more accurate by a process of independent review of the outcomes. Now, there's all kinds, it's a whole separate topic about whether these are useful and when they're useful and whether we should be doing it, but that's what I mean by adjudicated, okay? I thought you were gonna ask, Susan, what I meant by reasonable, and I didn't want to answer that because that's too hard. But there are some times when committees will want all kinds of information about they're really interested in the mechanism of action and they want all kinds of stuff. And then you'll say, would this influence any recommendation that you would make? And they would say, no, it has nothing to do with that. And then you have to say, well, look at the charter. We've got to be focused on recommendations that you'll make. So let's go back to the difference between the data monitoring committee report and the clinical study report. The audiences and the purposes are very different. The DMC report is using interim messy data. By definition, it's going to be messy. The clinical study report is using final locked data sets. Those are really different. The DMC's got to be flexible. The clinical study report has to very clearly separate what's pre-specified from what's not. The statistician in these two, preparing the statistical parts of these, have very different roles. The clinical study report statistician is very active before the analysis starts because they're figuring out what the analysis should be. And after, I said after the analysis is over, I don't mean after. I mean, after the study is over to do the analysis. The data monitoring committee statistician is active during the study and during the reporting process. So they're different times. The very often sponsors will think, oh, the DMC can use the same programs for the DMC report as we're going to use for the clinical study report. So they give the Independent Statistical Reporting Center the programs and say, run them. Well, programs start crashing because the data are interim and they're messy. There may be rules for excluding data in the CSR that shouldn't be excluded in the DMC reports, because there are lots of, in the DMC reports, the DMC data, there's lots of missing dates. You don't want to throw out data with missing dates. You just know they're missing. The data monitoring committee may need analyses that are irrelevant for the clinical study report and vice versa. The DMC cares about ongoing recruitment. How is recruitment going? The clinical study report cares about what was recruitment. The clinical study report has oodles and oodles of tables of subgroups. I never know why they do, but they do. The DMC does not. The report structure should facilitate review. The primary goal should be efficient review. And I wrote that before, and then I realized, well, it's more than efficient review. It's efficient review, but the data should be valid. I mean, it's not just efficiency for the sake of efficiency. You have to assume that the DMC members will not, or at least some of them, will not read the report very carefully. You will also learn, especially if you're meeting or in person, who has read the report really carefully and who hasn't. When you have a report, a physical report, people come to the meeting with the report, some people will have their report with the pages turned down where you know they've looked. Some will have little markers, you know, on their, what do they call those things that you stick on their report so you know what page?
Tabs?
That's what I'm, yes. And some will have all kinds of comments in them. So you'll know this person really, really read the report. Some will come with the report never having been opened, still in its envelope. And you know that person didn't look at the report, and then you will never recommend that person to a sponsor as a DMC member again. You can't tell that so much when you do this by hard copy. But you do know, and we've learned to warn people, when a report is done electronically, the ISRG can know whether it's been downloaded, whether it's been looked at. We had a case once, and I've never known quite how to do this, where we knew that the DSMB member had never gone into the folder, never looked online, but sent a huge bill to the sponsor with the amount of time preparing. And we made the decision, I don't know whether it was the right decision, but that we are not policemen, and we didn't tell the sponsor. I've always wondered whether that was right or not, but that was the decision we made. But what we've done since is we've told people, okay guys, you gotta know that we can tell whether you've used, whether you've gone to the report. So at least somebody would know I should go there. Whether we can't control whether they read it, but we know they go there. And now I think, you know, at least for who knows how long, everybody's going to be getting electronic copies, even old people like me that much prefer the hard copy. But when a report is done electronically, and this is going to sound so obvious, but I'm going to tell it to you, and then I'm going to give you some examples where you'll see why I'm saying it. It should be one PDF. It should be bookmarked. It should be tabbed. It should have page numbers. It should have cross-references. It should be something that somebody can read. It should have a table of contents. It should have summaries for ease of review, executive summaries, and we'll get back to that because not everybody likes that. I think it has text. I, like Susan, cannot do a report without writing text because it's only in the writing that I realize, oh my God, I don't understand this table. It should have appendices. It should have a protocol summary. I'm going to stop now and just see, are there any questions before we go to some bad examples that I'm going to show you? No questions? Then here's a bad example. This is the DMC report that I received when I was on a DMC member. I was a DMC. It came as a zipped file, and it had, you can't see the whole thing because there were 36 files, and they were labeled like this. No text, no nothing, just this. And I was supposed to go through each one, look at a table, figure out what it was, and this was my report. The other members of the committee didn't complain. I don't know why, but they were just, you know, this is the report. I complained. I said, this is not acceptable. I can't, you got to give me, I want hard copy reports. So this is what they gave me. I got a pile the next meeting with these in the binder. And I thought, well, okay, that's a little better. Maybe it'll tell me. But when I looked at the tabs, there was the tab, table 1.1, table 1.2, table. So the tab, even the tabs, it was just a repeat of the report. That is unacceptable. And if you're a member of a DMC, you should not accept that. I mean, I told them, next report, you give me a report with words, you give me a report with tables, with tabs that tell me what the table is, otherwise I quit. And they did, they improved. But how a committee, how a group thinks that something like this, or this, or this is acceptable to give to a committee that's supposed to make decisions and recommendations about safety of patients, I have no idea.
Janet, this is such a key point. I prefer hard copy too. I realize that, yes, I'm an old dog learning new tricks. I'm converting more toward electronic. But what to me is incredibly frustrating is that slide 1 or 2 before where we're sent something exactly, and I have to go to 21 different subsections to get each part, which is really not facilitating either use of my time, but also being able to integrate across. I was on a DMC recently, and I like this idea where we were monitoring 5 trials with 8 parts. And so, but we still got 8 open reports, 8 closed reports, and many other subsequent documents. And we had to go to more than 20 different places. And I could live with it there with 8 studies, but this is such a pet peeve of mine that if we're going to do this electronically, don't expect the DMC to go on to find 15 different or 25 different files.
Yes, I've had this experience also and had the same reaction. I said, I'm not going to have to open 30 or 40 or 50 Word documents one at a time. It's very frustrating. When I do mock advisory committees for some companies and I get an electronic version, typically I get something that Janet described earlier with a table of contents and a detailed outline where you can click on any piece and you know what it is and you can go right to that area of the report and see it. So most companies know how to do that. And so when they have a data monitoring committee, they should be able to make sure that the report that that goes to the data monitoring committee, they can give that kind of instruction to whatever statistical group is preparing it and saying, if you're going to do an electronic report, this is what it should look like.
Yeah, I don't know why they don't. I mean, I think what it is an arrogance that makes people do something as simply as they can and download the work to other people. But okay, so table of contents. Now, executive summaries. This is what's an executive summary? And right here, it can be helpful. It's a quick summary, a bird's eye view of what's in the report. It's not meant to lead or guide the Data Monitoring Committee's review. Limited information only, not the full picture. We like to do it at each meeting to have the previous meeting's executive summary. It's helpful to remind the committee of a big picture. We have had various reviews. There are some DMC members that hate them. They say these are leading, don't do it, get rid of it. In that case, we get rid of it for the next one. Some DMC members say, well, this isn't enough. We want much more. And so we'll say, okay, what do you want? Most of the people that we deal with have liked them and as they are. But again, as the servant, think of if you're an ISRG, you are the servant to the DMC and you should do what they want. So here's an example. This is a safety only one. This has occurred because it was so early in the trial, there was no, the efficacy data, it was a time to event and hardly anything had happened. But it gives you, here's the population, how many were treated, how many discontinued, how many died. Okay, very simple. And it gives the page numbers so people can go and say, okay, I'm interested in these serious adverse events. I go to page 58. Very simple. Other items an executive summary might include total patient years treated, deaths reported as of the cutoff. Now, one of the things about deaths, it sounds really easy to count the number of deaths. In studies that are ongoing, information from deaths come from all different sources. And one common thing that ISRGs often do, and I think we've been guilty of this too, is not stop and say, my goodness, I have death reports coming from 7 different sources. It's probably not 7, it's probably 4. I better put them together in one table so the poor DMC can know how many deaths there were. So it's very important to make it clear where these deaths are from. It's often in an executive summary good to have Kaplan-Meier estimate of death rates at say 12 months or 24 months, and then some information on the primary outcome events. To facilitate the review,
By the way, if you're just, Janet, real quickly on that executive summary, I have the same sense about these for DMCs as I do serving on FDA advisory committees where briefing documents have executive summaries. I think it's important in both those settings to review everything. And my worry is that if you have executive summaries, people might in fact be more inclined just to read the executive summary. Nevertheless, I support the idea because it's better that they have at least seen that than nothing.
Well, the executive summary in the FDA advisor committee can be like 20 pages. It can be a big thing. I'm not talking about this. I'm talking about a half page or 1 page, just very, very bare bones with no text, because text is then can be too leading. And very often when we do this, the DMC members will say, next time, I'm interested in renal function. Can you put a line for the renal problems?
Right, they are shorter, surely, than what you see at the advisory committees. But when I've seen them, they can be 5 to 10 pages long based on who's doing it.
Oh, okay. So these are, information should be organized efficiently. You should highlight important details, but not be leading. And that's a subtle difference. Explain where information can be found. Omit useless information. I'm going to give you an example. display information in an appropriate way. If you have 10 patients, don't give a big table, give the listing. Transition to tables and graphs over the life of the project. And you may need to add subsets as data accumulate. Some statistical groups are limited by their programming templates. And some presentations may not fit into their templates. And I'll give you some examples. So here's some examples. All right, here's a table of ECG. This is QT interval in milliseconds. So this is an important outcome. Worst post-baseline value. We're worried about values in the 480 to greater than 500. And you look at it and you say, oh, look, there are all these people and there's all these numbers. And you say, there's a lot of zeros in here. And then you look a little closer and you discover that all the data are missing, all right? There's only 2 lines of numbers with numbers, and one is missing and one is total. Do you think I made this up? No, this is a report that I got when I was in a DMC member. This is useless. Here's another one, 44-page table, Group A and Group B. This is a cancer study, so it's in grades rather than in SAEs. And Group A has grade 1 and 2, and grade 3, and grade 4. And oh, look at this. For those of you who don't know, grade 4 are life-threatening events, so they're really important. Group B doesn't have any grade 4. That's really good. Aha, but there they are. They're on the next page. Now, it turned out that there were 9 grade 4s, but it was on the next page. So that's not very helpful.
By the way, that's, sorry to interrupt you, such an important point. So frustrating when this happens, and it happens. Such a key point.
Yeah, and it's because people aren't thinking of, if I were reviewing this report, what do I want to see? So here's a 148-page table with a p-value that is, I mean, who believes in p-values of 0.2667? Just over precise.
I don't think it's not that I don't think it's that people are not thinking so much. I think it is that people give low estimates to companies about how much it's going to cost them to prepare the reports. And this is the way SAS spits it out. And they feel like they can't afford to reformat the table. SAS, you can make very nice tables in SAS. You don't have to print it out this way. You can almost make them look like they were prepared for a publication. But people don't do that because they want to get the business, and so they don't, have the wherewithal to spend the time doing the extra programming. I think it's more that than that they really don't, it doesn't occur to them that this is hard to read.
Right, and the reason it's important is that if there's something in this safety data that in these 148 pages that is important clinically, who is going to see it? This is Jean Rouleau's needle in a haystack. So,
and the reason that I think it often has to do with money is that one time I was on a committee where we got a document, a hard copy with lots and lots of tables, just like you showed, table 1.4.8, with no words. And then people would say, let's look at this particular table, and you couldn't find it in there. And I said, why don't you give us something with page numbers? So you can say, go to page 89 and we can find it. And the answer was, it would have cost them a huge amount of money to page the report, consecutively. SAS pages each individual table. So you had page numbers for each table, then it would start again with the next table. So that's now, and of course, what I said to them was, somebody must have a 10-year-old kid, give them a marker and have them just write all the page numbers, and then you can make copies of that. But I think that's why it seems to me that it's a money issue.
I think you're probably right. So I'm
But
just,
whatever, you really need page numbers when I'm talking to my colleagues. It's the easiest way for me to get them to where I am with the page number.
right. So these are just some more examples of tables that are impossible to interpret. Go on and on. Just here's an 80-page table, on and on, that you can simplify. So these are simplifying with still a couple of, going from 148 pages to 80 pages with a couple of little simple things, but much more important to make it more interpretable.
Janet, these issues are so important where when we're looking through these documents, what is the most efficient way for us to be able to ensure we're going to see and understand what the key insights are that are emerging in the trial? And among the things that you mentioned that are absolutely frustrations are the tables set up in a way to allow you to really see things in a very clear and efficient manner? Are these paginated so that, you know, I find myself making the key observations when I go through the report, and then I try to prepare so that when we have our our closed session, we can be efficient as a committee to go through what I've seen, what others have seen. And very often I will identify 10 key issues that I want to bring to people's attention, and I want to prepare and do it where it's efficient. And I want to be able to have the independent statistician, particularly in nowadays with virtual meetings, to be able to call up those particular tables that I'm referring to. And I rely on being able to have pagination, not just table numbers, but pagination. And some of these independent reporting statisticians have been really good. You know, when I give them that, they can pull it up right away. I can now allude to this to my colleagues. We can talk about the issues that are really relevant there. So these issues that you're mentioning are absolutely critical to not only facilitating our ability to understand what we need to learn from these reports in a reliable and efficient way, but how to communicate it in an effective way while we're working with each other in meetings.
Yeah, and I would like to, so this is a message to DMC members. Don't accept these reports. If this is what you get, remember, if you are if there's a safety issue embedded in this and you've missed it because you can't see it, you're responsible. Whether you're responsible in a legal way or not, I mean, you're ethically responsible. And so if you have receive a report that cannot be read, cannot be interpreted, you don't know, you can't find things, you should protest. You should tell the reporting group, no, this is not an acceptable report. And Susan may be right. It may be that they've negotiated a really low price. That's their problem. And sponsors should recognize when they see a price that's really low, it's probably because they're getting things like we just saw.
Indeed. So if that hasn't been, if we don't have a quality independent reporting group as you are to push back on the sponsor, then it falls on us as DMC members, and it should start in the organizational meeting. And I realize that, as it was Susan, I think, was saying yesterday, when you start seeing the evidence, then it's much clearer to you as to whether the format and content of the reports that you're getting are adequate. But there's still a lot that you can see when you're shown the templates in the organizational meeting, and it's up to the DMC to be assertive here, not passive, to be able to speak up. One of the things, you mentioned it, that seems to come up in almost every organizational meeting that I'm on, is for some reason we're wedded to the idea that the way you present continuous variables is the mean, the median, and the quartiles. And that includes lab values. And as we were alluding to, that's not the clinically relevant insight to effects on lab for many lab values. And so I have to say, so often these organizational meetings to my colleagues, please, let's get the clinicians from the sponsor and the clinicians from the DMC, and maybe some of us as biostatisticians, to have a meeting going lab value by lab value to talk about what are the thresholds? And if it's QTC for Risha, I want to know how many people were above 500 milliseconds and 450 and how many had 30 and 60 millisecond increases. That's what I want to know. And yet so often it's just this knee-jerk mean, median, quartiles is what we're going to show you. And so often people don't push back on that when they should, at least until they start getting the data and then realize that they're not seeing what they need to see. So much of what we see is completely outside of what we really need to learn. And you end up getting a voluminous, it's almost like how to find the needle in the haystack. So these issues that you're raising aren't hypothetical. They happen all the time and they're critical to the effective ability of a DMC to learn the information reliably and efficiently and to be able to communicate in, unfortunately, meetings that are all too often too short, closed sessions, to really understand each other's views and insights about this.
One thing I have started to do when I'm asked to serve on a data monitoring committee is I've asked to see a sample of a report of the statistical group that's going to be preparing the reports for the meeting. And if I see stuff like this, I'll say, no thanks. I'm not going to be on that. I'm not going to be on that committee.
Do the groups preparing these reports necessarily have the clinical expertise to know what the needles are in the haystack that they should be highlighting?
That's a really good question, Katie, and that's why it's so important for the status, if you don't have medical people in your group, to develop very quickly a really good relationship with the chair, assuming the chair is a clinician or a clinician on the DMC who will discuss it with you. And you don't be bashful about it. And they want to. They want to tell you what are the issues that they're concerned about. Are you, what are the values that you should be worried about? So don't take it as, don't be bashful about asking questions if you don't know the biology. I want to mention something about mins and maxes, because we know in statistics that mins and maxes are kind of lousy measures because the larger the sample size, right, the minimum gets smaller and the maximum gets larger. So they're not good measures of central tendency at all. And that's why we use 25th and 75th percentiles. But when the mins and maxes are things that are related to clinically important events, then they have to be shown. And that's why it's important to understand, to go when you get let's say you didn't know about potassium and you get an 11. So you get all these 3s and 4s and 5s and 6s and you get an 11. So you look it up. What happens with an 11? The person, that's inconsistent with life. So you know that that number is wrong. But when you see the creatine kinase, and you don't know those numbers, you look it up and you say, oh, it's consistent with life, so I'm not going to throw it out, but I better speak to the clinicians and say, what else should I be looking at to see if this number is real?
I think generally these kinds of data, these laboratory data, are much more easily processed if they're presented as graphs, like the one that you showed before, where you can see what the mean and median are, and then you can see all the ones that are above or below the quartiles and how those go. That really gives you a good sense of what they're, those kinds of plots.
But see, even this is you can't just spit them all out, because if you spit them all out, you get this, right? Which is not informative with respect to the bulk of the data. So you have to you spit them out, but you also think about it. And I'll show you some examples from Wisconsin that shows how to, I mean, the more you can automate, the better, but don't automate too much. Okay, I think it is time for lunch, for break, whatever, and we'll be back at 1:30.
Exactly, Janet, great. And as we're breaking, just to make one more point, it's reiterating what was said, but when you're sending these reports out to DMC members and they have to get them online, Why can't it be done where you can click one time and get the entire DMC closed report, and you can click one place and get the entire DMC open report, rather than to have to click 18 times to get the segments of the DMC closed report? That's such an important issue for ease of access for the DMC.
Yeah, it's very easy to do. I mean, if you just take your SAS output or whatever output you have, you put it in Word and you paginate. The paginate's automatic. It's really easy. This is
exactly, and that's the thing that baffles me, is that it should be very straightforward to do that. And when you've made the job of all the DMC members so much easier. So in any event, this is excellent. We will break for 30 minutes and pick up again at past.
So this morning I talked about, or whatever time it was, depending on where you were, I talked about bad things. What I'm going to try to do today is talk about good ways to do a report. So first, a word about hard copy versus electronic. We did that, we mentioned that before. If I had been given this presentation in 2019, I would have said, remember, some people hate electronic, some people hate hard, so give everybody what they want, and remind the DMCs that we have access. The ISRG knows whether you've accessed the report. So in the COVID-19 era, which looks like it's going to be longer than we thought it was, we have to go electronic. But we need to strike a balance between confidentiality and usability. One of the things that I know a lot of people complain to us about, and I complain to people when I'm on the committee, is how difficult it is with all the precautions to get into the report. And you need to figure out a way to not have too many layers of passwords, but that's a small comment. Remember that reports evolve over time. These are not fixed reports. As Susan said yesterday, report templates are boring to look at, and not only are they boring to look at, you don't know when you see the report template what it's actually going to look like when it's populated. So you're going to run into changes because of data monitoring committee requests. Now that the tables are populated, people are going to say, well, I didn't mean to like that. So there are going to be changes for that. There are going to be safety signals that come up, and they're going to require further exploration. There's going to be there may be results from related compounds. So your study may be some drug, but there's a related drug that has been reporting out safety concerns or efficacy or something, and you may want to tailor your report to what you've learned about or what the DMC has learned about in related compounds. Then the DMC may be contemplating recommendations to stop the trial. This is for efficacy. At that point, the DMC, you may want to do a bunch of subgroup analyses to make sure that there's not something really weird going on, that it really works overall and it really works in men but doesn't work in women at all. And the concern would be if you stopped early, there'd be too much uncertainty.
By the way, the Zygris and Apache score could be one good example of that.
Yes, yes. Do you want to describe that, Tom?
I could. Basically, I was the 10th vote on the 20-person advisory committee that made it 10-10 because there was a lot of uncertainty there. We've never had a success in Zygris, excuse me, in severe sepsis and being able to improve survival. And Zygris, the study had the most encouraging evidence to date, suggesting a survival effect. Even I think you would know, Janet, hitting an O'Brien Fleming monitoring boundary,
yes.
And yet it was a single trial in the context of so many other failures, and there were, as is the case in any trial, so many aspects to the richness of that, including what our advisory committee struggled with was a strong interaction by Apache score. And so these were issues that left the advisory committee evenly split on whether this was adequate information for the first time ever in severe sepsis versus not.
And actually I was on that DMC, so Tom and I had different aspects of it. And so it was really an interesting case. The first half of the study, there was no benefit at all. And the second part of the study, it was really, the benefit was so great that the overall p-value for the O'Brien-Fleming was significant. And we struggled a lot about whether to stop, and we felt we had to. One of the reasons we had to was that the reporting group wouldn't give us more information. And we wanted some extra analyses, and they wouldn't give it to us. They weren't paid for it. So I don't remember what the reason was. And as a committee, we felt that in the absence of the data, maybe we should have made the other decision, but that given this very strong result, in the absence of real exploration, we better stop. It was a very difficult decision, and one could argue that in the absence of more information, we should have continued, but it was sepsis and it was a dramatic result. Very difficult case. So that's why, you know, those of you who know me know I don't usually like subgroup analyses, but you don't want early stopping with ambiguous results in important subgroups. And here the subgroup was, and later on we learned that the manufacturing had changed in the first half and the second half, but we didn't know that at the time. You want to make sure that the primary endpoint the finding is robust, and that if you did another analysis, it would still show. Whatever you did, you kicked the tires. You want to make sure, you want to do conditional power calculations under a variety of mechanisms. Susan suggested doing it under the alternative. I feel you should do it under a variety of assumptions, not only the alternative. And then there's also the intellectual curiosity of data monitoring committee members. I don't think that's a good reason for changing your report, but it is a good reason to say, and to ask the DMC, why do you want this? How will it affect your decision making? It's impossible, and this is another important point, it's impossible to anticipate all, I love that I'm using the word anticipated twice. It's impossible to anticipate all changes that can be anticipated, right? You don't know what changes are going to be made. And very often sponsors only want to send data for those analyses that are pre-planned. I strongly believe that the reporting group should get all the data, because only when you get all the data can you answer questions that hadn't been anticipated. There may be, and if you go to the sponsor and say, sorry, oh, by the way, I need data on, I don't know, on lipids, they know something's up. So you shouldn't be in the position of having to ask for specific data. You should ask for all data.
By the way, strongly agree with that as well. That if you're coughing there for a minute, it's really a good point that if you have all the data, you're in a position to really have the most timely and insightful responses when the DMC asks additional questions. And you're right, Janet, we want you to, as a reporting statistician, to be able to do that without having to tell the sponsor that you're having to do that.
Yeah, and this is where the sponsor really has to trust you. Because the sponsor could say, I'm giving you all this data, you may be just spending a huge amount of time and billing me a huge amount of money, doing all kinds of unnecessary things. So you have to have a really good relationship, and they have to understand why you want it. You're not going to do analyses just for the sake of fun. Okay, so what we like to do, and this is not what everybody does, and I know there's objection to this. Before we have a meeting, we like to have what we call a walkthrough. We take the whole study team and we sit them around the table with the report, and we walk through it and try to predict what questions the DMC is likely to ask. And then we try to prepare those analyses so that if they come up at the meeting, we will have done it. We can't always know, we can't always predict what's going to be asked, but we're more comfortable doing that than having a question asked at the meeting and then running the analysis, because we're always nervous that we'll do that wrong. So instead, sometimes if there's a question that comes up, we'll say, we'll get back to you later, and we define the meeting as the time from starting to the time that the questions have been answered. But there are people, and I know this is true because I was involved in one case where the DSMB had been given, over the life of the product, of the study, the wrong treatment codes. And I was asked to come in and figure out how this happened. They were given dummy treatment codes, and that's what they observed. And since there was no harm, they just let the study go on. There was no harm and no benefit because it was all random allocated. And what I learned, so I spoke to people all down the line who were preparing the report. And what I was told over and over was that only one person was allowed to see the report. Because the question that I asked was, well, why didn't anybody notice that there was no difference? Why did it look so much the same for so long? And the DMC kept on asking you, are you sure, they kept on asking you, are you sure the allocation is correct? The treatment code is correct. And what I was told was that the sponsors insist that only one person from the CRO see the data because of the sensitivity of the data. My own belief is that that's really wrong, because it's really hard for an individual person to know everything and to make good judgments. And I think it's much more important that more than one person have access to the unblinded data and be able to think about it. But again, that has to be only if everybody involved understands how sacrosanct the data are and that they must be kept confidential. And let me ask Tom and Susan, have you had this experience too, where the ISRG is limited in the number of people that are allowed to look at the data?
So we've run into these instances that you've referred to where because of limitations, there have been settings where the coding hasn't been done correctly. I'm just scanning through in the second edition of the book, the sponsor where often sponsors aren't happy to have their dirty laundry aired, so to speak. And this one, I'm really impressed, said, yes, you can write up what we learned, because it's really important to understand how to prevent this happening in the future. And I'll be referring to a case tomorrow. So let me have you carry on here. And if I can find the place in the book, I'll come back later on and tell people where this is.
Okay, so then let's talk a little bit about the meeting. Who guides the review? And in my experience, this is very variable. Sometimes it's the reporting statistician. Sometimes it's the chair. There's one chair that we work with, and I think this works really well, especially, and will work really well, especially the COVID situation, where that chair assigns topics to each DMC member. And each DMC member has to go through, lead the rest of the DMC in that report. And that forces everybody to really read the report. And then whoever guides the review, that will change over the course of the trial. And the other thing is how quickly to go through the report. And this is going to vary with the life of the study. When a study is brand new and it's hardly anybody there, the report is very quick. When the study has begun to recruit people and there's begun to be data, those take often a long time because people are looking at it, they're trying to see signals, they're trying to ask, what else should we be seeing? But then later on, when the trial is toward the end, is very mature, there's hardly any differences. People say, oh, we've seen this before. So it varies a lot. So then there are open reports, and I want to spend a little time on open reports because an open report is a report that the sponsor sees. The presentations include only the pooled totals, no information by treatment group, and it informs the study team about recruitment, about pool data on adherence, perhaps. It provides a common document for discussing issues, and sponsors like it to check the accuracy of the reporting group. There are dangers with these open reports. It's an extra expense. It often gets in the way of more important activities. There is a potential to unblind, and it may no longer reflect what the DMC is seeing in the closed report. So imagine reports are going on, the closed report is changing over time because the DMC says, now I want to see renal events, now I don't need to see the baseline data anymore, now I need to see this. So the closed report is changing. But the open report better stay fixed because changes that are in response, changes that have occurred in the closed report in response to questions from the DMC should not go into the open report because that will clue if all of a sudden there's a whole new bunch of tables on renal disease, the sponsor will know, uh-oh, the DMC's been seeing something. So this is our experience is very difficult to do both open reports and closed reports in the same study. If you do them, it's really important to preserve the blind. You should avoid subject level data because even when you think they're blind, there's always something, very often something in there that tells you what the patient got. Different sponsors request different amounts of data. Some only accrual status and baseline data. I don't know what I meant by that funny little thing. Sometimes limited follow-up data, but some want all or most of the closed session analysis in aggregate form. I think that's really risky. And then, as I said before, if the DMC requests specific analyses based on concern raised in the closed session, don't include it in the open report. But that now means you've got 2 teams programming. It's very labor intensive. So my tips, limit the content, baseline only. Especially wary of including listings, limit the text. And then what we've learned is to send the open reports after the closed reports. Do the closed report, that's the one that really matters. Then do this open report because then it eliminates it doesn't completely, it minimizes the chance of making an error.
But Janet, don't you want to have the data that relate to trial conduct, like dropouts and timeliness and those kinds of things in aggregate in the open report? Because that's where you discuss, sort of how the study is going and whether there are quality problems.
Yes, but we often, I agree with you, but in very succinct ways, because often what people will look at is, are the dropouts different by treatment group? So it really has to be just the overall.
Oh yes, of course, just the overall, but even so, the overall can give you a picture of whether there's an excessive amount of dropouts or whether the timeliness is really bad or whether there's a lot of protocol deviations, that sort of thing. And the committee would want to discuss that with the investigators and the sponsor, which they couldn't do if it was only shown in the closed report by ARM.
Yeah, no, I agree with you.
And I agree with both of you. I think it's critical, as Janet and Susan are saying, not to take the closed report and then just and present the entire closed report for all the reasons that Janet said. The open report should be, as Janet's saying, laying out these elements, focusing very much on baseline. But as Susan says, and I would argue this as well, I do want to see pooled data across intervention groups for quality of study conduct measures. So issues around adherence and retention, but not efficacy and safety.
Yeah. And then it's important to really keep good records of what went into the closed report and what went into the open report. The other thing we've learned, so you have an open report, and let's say you do an open report with the issues related to to quality of the data. Sometimes in the report, you don't realize it, but in some of the listings or someplace, there's a group label that's there in the data, and you don't realize it's there. So what we've learned is when we're doing an open report, we always search for the group labels and make sure it's not there. And then the other thing we've done, if the report is big, if the sponsor wants a lot of things in it, we say, look, if you really want it, can you, one person at the sponsor who is removed from the study, can you look at the report before you send it out for wider distribution, just to make sure that we haven't made a mistake, that we haven't inadvertently put something. So you can see we're very nervous about open reports. Fortunately, we've never made a mistake, but there are times when we almost did. So when it's there, but the grace of God, and so we're very nervous about that. Okay, in doing a report, use a sensible mixture of tables and figures, and you're going to find that there are people who much prefer figures and people who much prefer tables, and some want some and some want both. And sometimes you're going to need to show the data in both ways. As we talked about text, I really think, and as Susan said, that reports should have text. And we often have sponsors who don't want to go with us because they'll say, we don't want to pay you for writing anything. We don't want text. Text needs to be explanatory. It needs to tell it can be short, it doesn't have to be long. It needs to tell the reader what they're seeing. It needs to describe if there are things in the tables that need interpretation, it needs to say that. And then, as I said before, if the data meets very frequently, you don't need text because you know the DMC knows what's going on. It doesn't need to see it. But the less frequently it meets, I think the more text you need. Okay, I want to just, any questions before I go to specific types of data or any comments? Then I will go. So I'm going to talk about some of the challenges of working with interim data, and then I'll do some specific things. If you think about data, if you're a student and you're taking a statistics course and you get data to analyze it, you usually have, it's very simple, it's complete, it's clean. Its purpose is to allow you to practice a newly learned method, or it might have in that data set some specific problem, a certain amount of missing data or some outlier, something so that you can learn how to deal with that. It's toy data, it's artificially dirty. Data for final analysis, the analysis is typically based on a final lock database. All the data is in one database, including the treatment code. The database structure and the checks have been finalized. The data is not going to change. You're not going to do the analysis and then 2 days later the data is different. It's going to stay the same. The data are complete and as clean as they will ever be. The queries that can be resolved are resolved. The adverse events are reconciled, the endpoints have been adjudicated if there's an adjudication committee. It doesn't mean you should trust the data. It just means the data are fixed. In programming data monitoring committee reports, the data transfer itself may be difficult. You've got two organizations and they don't know how to transfer data. The quality of the data may be problematic. Some of the data that you need for the analyses may not be available yet. Some may be really distressingly incomplete. And then a subtle thing that can happen is that the data that you have may not reflect the order of occurrence. Data that some centers send their data in quickly, some centers send their data in late. And so you may be seeing a distorted sense of what the data will be. They're not coming in randomly. There are multiple sources. There's a snapshot of the clinical database. It's a randomization list. The safety department sends you serious adverse events. The lab data comes in from one lab, from another lab. The ECG data comes. So they're coming in from all kinds of sources. The formats are different. There are multiple transfers of data that come and go. And the database structure itself may change because at the central place where they're working on the data, it's early in the study and they're working on the database structure. So, and the ISRG may be the first or only external group receiving the data. There may be failed transfers, missing data sets, corrupted data, incompatible format. Everything that could go wrong may go wrong. So you're dealing with, and your procedures and your systems aren't fully tested. So our view is, don't think of trust but verify, but think of don't trust and verify. I mean, you've got to do the best you can. Test your processes early and often, like voting in Chicago, in as realistic manner as possible. And use the documents. Use your annotated case report form so you know what the data are. That sounds obvious, but often not done. Look at if there's an adjudication committee, look at the charter to know what is the adjudication committee doing. Look at the sponsor's statistical analysis plan and the protocol. Look at the investigators for sure. What do they investigate? What have they been told? And ask for drafts. Just get all the drafts. And one of the things that we've found, and we're kind of shocked about it, is that very often sponsors will change a protocol, will modify the protocol, but we won't get the modified protocol. And so we're operating assuming one thing and the protocol has changed. So make sure you get all the information you can. We like to have frequent transfers, not just before the meeting, just every week or every month, send us the data. CROs will say that's really, really expensive. I've never believed it. I don't understand why that's expensive. It seems to me that should be very inexpensive. But if you have a constant stream of test transfers using real data, you can do your programming, you can really learn. It allows you to identify issues early, and then you have the data in hand for ad hoc analyses. Make sure that you get cumulative transfers, not incremental. A lot of sponsors will say, we'll just give you the incremental stuff. Well, very often there's been changes in the stuff before and you don't get that. Make sure you have enough time between the transfer of the data and the meeting. And then consider the relative timing of data that come from different sources. You may get, some lab data may be much delayed over other lab data. So make sure you understand when the data are coming. And there's always a trade-off between the quantity and quality of data. You have to accept that their unclean data means some of your data will be incorrect and inconsistent. Some will be impossible and implausible. Some will be inconsistent. I can't tell you how many dead subjects we have seen who have further follow-up. They die in one day and two years later, they have a meeting, visit. So you have to accept that there's going to be all kinds of messy data. But in general, I think those of us who've been doing this feel that using more dirty data is better than using less clean data to an extent. How do you deal with dirty data? You use simple, easily defined, and sensible approaches, remove or convert implausible or impossible data, and use sequential hierarchical definitions for key measures. For example, if you want a death date, if there's an adjudicated date, there's an adjudication committee and it has a date, use that date. If you don't have that date, then use the date that they potentially died. Don't have that. If you have a death date in the serious adverse events data set, use that. Otherwise, if there's an end date for an adverse event that's coded as fatal, use that date. So think of it, and those dates will very often be different. But if the adverse event says that the event resulted in death and the death form isn't there, I like to assume that the patient is dead, because my view is that missing forms are more likely than plausible data. So these are all judgment calls. What's fun about dirty data is it lets you use your statistical prowess, right? You can use robust analysis techniques, you can use non-parametric stuff, you can use trim data. But again, as I said before, avoid mins and maxes except if they represent safety issues. And then when you're doing analyses, be able to explain in words that the DMC can understand. So here's some examples, and you'll think of lots of others, but I just want to give you a principle. Supposing you have the same data from multiple sources. You have serious adverse event data from the safety department, and you have adverse event data, and some are marked serious. So one approach is to say, I could use one and I'll ignore the other. Another approach is I can report them separately, clearly identifying the sources, or try to combine them. So make a decision about what you're doing and make it clear to the DMC how you dealt with it. If you have visit codes versus dates in the final analysis, people often use windows. You're going to have to think about methods to reconcile multiple measurements within the window. Again, I don't think it matters what decision you make, but make a decision, use it, and make it clear to the DMC what you did. And then if they don't like it, change. And try to be, impute missing or incomplete data logically. If the study, I've seen all kinds of illogical dates. If you know something happened after, if somebody has an event and then they have another event that occurred after that, but the date makes it before that, use your sense rather than the dates. Remember that the follow-up is going to be incomplete because the trial's in progress. So you need to distinguish at least 3 kinds of missing data. Data that will always be missing, right? Data that are never going to get collected. Data that haven't yet been entered. So they're missing in your data set, but they're not really missing. They're just not entered yet. And missing data that's under query. So you have the data, but it's under query. And those, again, problems that distinction is not a distinction at the end of the day. It is a distinction when you're trying to do a report, a DMC report. And then you have uncoded data. So you have adverse events with lots of uncoded data that are unadjudicated. But don't go nuts trying to make everything clean. Think about what's important. So again, put yourself in the head of somebody who's trying to make a recommendation from these data, and then try to figure out what needs to be clean and what can be dirty. And you explain to the DMC, we didn't clean this because it's not something, it's too messy and we don't think it's relevant to your decision. On the other hand, to your recommendation. On the other hand, if they say, no, there's something that's really important, then you got to go back and deal with it. It's important to explain to the DMC what data are available and what data are not there. You want to know, they need to know how much data are in the database, how many people withdrew, how many people were dead, and how much data is expected but missing. You need to distinguish somebody who has died, has completed the study. One of the things that always bothers me is that his study is not complete. The study is complete. That person isn't going to do anything more. So that data, that's complete data. And if there's a huge amount of uncoded, unadjudicated, really messy data, the DMC can act by complaining and can complain to the sponsor, hey, we can't review these tables, this study adequately because your data is such a mess. Okay, so again, some distinction between final and interim data. You can think of final analysis as pre-specified and confirmatory. You've used sophisticated approaches for maximizing power and efficiency, for eliminating noise. It's the basis for regulatory approval, and you don't have room for hunches about possible signals. You may have room for hunches about your next study, but not about this particular study. Interim analyses are by their, and I'm using interim analyses here in the broader sense, not just formal interim analyses for efficacy. It's exploratory by very nature. You're looking for, the DMC is looking for unanticipated safety issues. Anticipated safety issues are there in the investigator's brochure. They're there in the informed consent document. So it's the unanticipated that you're looking for. You're looking for a potential signal in noisy and complex data. And remember, you have to think about how are AE data collected. Somebody writes down, an investigator or a physician writes down some words that describe the event. That gets coded, and then that gets coded into several levels. The same event may get coded into different codes depending on the country and the doctor's way of describing a symptom. So these are really messy. Here, hunches and dead ends are important, but the Data Monitoring Committee shouldn't ask to the DMC, we talked about this, the ISRG, to act on every scientific hunch. You want simple descriptive statistics, robust techniques to the extent that you can hand, and to the extent feasible, data visualization, because you've got a busy audience. You're going to have analytical conventions, but they need not, and they sometimes should not be the same as the final analysis convention. So when you think about the conventions you're using, think about, I'm looking at messy data that are on the way. So what about p-values? Some people like p-values as screening tools. Some people object strenuously. My view is just do what the Data Monitoring Committee wants. If they want them, give them. If they don't want them, don't give them. But please don't use over-precise p-values. And then in general, and Susan mentioned this, try to organize your information from a summary down to detail, so that's a hierarchical approach. So here's going to be some specific types of data. And these are in relation to trial conduct, baseline data, safety data, and efficacy data. So these are the 4 kinds of data that DMCs will look at. So accrual, and this is early on in the study, this is what the DMC cares a lot about. How is the actual accrual progressing compared to projection? At the end of the day, as I say, you don't care. You know how many people were in there, but during the course of the trial, you want to know, how is it happening? Are enough people going to be recruited? Are new countries and sites being added, or are existing sites recruiting new subjects? are certain sites dominating the accrual. And you also, of great interest is the geographic breakdown in international trials. Has the geographic makeup of participants changed over time? There's a special case of China, and this is a really interesting story. The Chinese centers often don't enter until pretty late in a trial. So the trial's been going on, and then China enters. If the trial is a trial, suppose it's a trial that's a lipid, just looking at lipid modification. Look at lipid modification, the survival curves or the time to event curves stay the same for about 2 years. And oh, you can't see my hand. Oh, I can get, they stay the same for about 2 years and then they start to split. Okay, and that's a typical thing that happens in HDL and LDL lowering trials. If the Chinese population starts entering 2 years late, 2 years later than everybody else, all their data is still on the path where the trajectory hasn't changed, where the curves have not splayed. So that, now, of course, if you were fortunate and you're doing a study that had proportional hazards, this would not be a problem. But that becomes a very important issue as you're looking at efficacy data with countries that enter late in a trial because they're not on the part of the curve where you can see benefit.
By the way, that's classically the case now in immuno-oncology with checkpoint inhibitors. Because if you're looking at, particularly in a biomarker negative group, and you're comparing to chemotherapy, hazard ratios in the wrong direction early, and it's powerfully positive long-term. It's the opposite of chemotherapy. So if you're on a monitoring committee, and I've done this in the chemotherapy era, I look at the curve, see what the hazard ratio is, but look at what the time varying hazard ratio is. And I'll say to my clinical colleagues, if it's chemotherapy, it's going to get worse over time, and it gets worse over time. Immuno-oncology, it's the opposite. So that's, seeing those curves and understanding that the ongoing estimated hazard ratio is the weighted average of the time varying hazard weighted by where the events are, that has to be understood.
Yeah, and it's very often really useful to show Kaplan-Meier curves. Here's where Kaplan-Meier curves of various subgroups make a difference, because you're looking at subgroups that are coming in at being accrued at different rates. And I just hope that China will start entering trials earlier. That would be very good. So in the beginning, what the Data Monitoring Committee is most interested in is accrual and really bad SAEs. I mean, they're unexpected. So you want pictures of it. Here are some pictures. Here's accrual over time. Here's a funny graph where accrual got really big and then slowed down. But so you want to show accrual over time. You want to show the distribution of sites by accrual. We like to show, sometimes you'll see, this is the number of subjects recruited and the number of sites. Very often you'll see a slide with, this is one subject, you'll see a big spike over here. That's a kind of a worrisome slide, that you have a bunch of sites with only one patient. But these are very useful. You can see what the distribution is of the size of the sites. And sometimes you'll have a site, distribution like this, and one that's like, here's 16, and the next one is like 45.
You might have zero also, since so often we have zero entered. Obviously, that doesn't tell us about the current data, but it tells us about the future.
Yeah. You often want to see it by region. And I will say this, I don't know where sponsors learn their geography, but we see in Europe things like Australia. It's as if, oh, I don't know where to put Australia, I'll throw it in Europe. So what we do, we put because we can't stand putting countries in the wrong place. We had one where Venezuela was in Asia. So we put them in quotes, region in quotes. You may want to do it by tables, but this information is really important to give. Disposition. You want to know, are subjects discontinuing from treatment early? If so, why? And is the discontinuation does it differ by treatment group? And then a really important piece, are subjects who have discontinued treatment continued to be followed? And lots of studies don't make the distinction between stopping from treatment and stopping from study. And that is something that sophisticated DMCs are very aware of, and they will often go right back to the sponsor and say, you've got too many people not being followed.
Thanks, Janet. That's such a critical point, that so often it's misunderstood and people think non-adherence should be non-retention. And that's one of the biggest sources for non-retention. And you're right, DMCs need to have that information, be on top of it from the very beginning, and be on top of the misuse of the term withdrawal of consent, which doesn't mean that a person stops therapy and the investigator says, oh, maybe we don't want to follow you. So those are issues that are critical and come up a lot, and DMCs have to have the information to be on top of that early to correct the issue.
Yeah, and it's a really important thing that they can do, because if they notice it and if they correct it, that can save the study. So this is something really important, one of its very important roles. You want to know all kinds of things about subject status, reasons for discontinuation, and part of that you want to know, is there a way of discouraging discontinuation? Are there reasons for discontinuation of treatment that could be prevented? So they want to know that, and the DSMB is in the, basically the sponsor should know that also, but the DSMB is really keyed into these kinds of issues in a way that often people on the ground are not. So here's a graph of recent subject status. Here's the ones that are on treatment still. Here's the ones that are off treatment. And you can see in this graph right away that there's a difference in these two groups. These are one-to-one randomizations of the people who are off treatment, withdrawn from study, higher than in the control group or in the other group. You want, here's reasons. So these are graphical presentations, really easy to follow. These are Wisconsin's graphs. You do a consort-like diagram is very useful, so you can follow what has happened. Here's 147 people, what happens to them over the course of time. And this will change a lot as the time goes on. These numbers, these move down. You may want a graph of time to early discontinuation, right? And here is showing a really consistent difference between these two groups. And these are subjects terminating early. So these are the people stopping study. That is really worrisome. You may want a graph of follow-up time. You may want information on dosing. So here's a, this is a group which has, the group is Fuji, and they were, here's the Fuji group, and here's other drugs that they were given at the same time. You may want protocol violations, not the silly little deviations, but the ones that matter. Ones that you entered the trial without meeting the entry criteria. You met the withdrawal criteria, but you weren't withdrawn. That's important, right? You had some really bad thing happen. You stayed on medication. You excluded con meds. So these are the big ticket violations that affect the safety of the participant and the interpretation of the data. You want information on how much data was in the report, how recent are the data, and how much data are available relative to what you would have expected had the data been collected quickly. And I can tell you when Tom is on a committee, he's really on top of that, which is really good. Because what should the DMC do about lack of availability? The DMC has a very strong, influence on sponsors. When they say, we are not happy, we can't interpret this study because the data are so slow, or we can't interpret this study because the adjudication is so lagged, the sponsor will respond. And it's good for them, and they're happy to. We present a table like this that gives a little sense of how current the data are. Here's another one. This is a Wisconsin study, a graph that gives different ways of presenting currency of data. This one shows that, that nothing is late. Basically, nothing is 4.5 months late, but there's lots of data late, 2 and 3 months late. Why do you need baseline data? You want to know who's in the population. Have they met eligibility requirements? Are they what you expect? Should you be trying to recruit certain types of participants who should have been in there or not? What are the important baseline characteristics for understanding the disease and the prognosis? And then, are there important imbalances by treatment group, particularly for prognostic variables? And if so, does this reflect chance or a failure of randomization? So for baseline data, focus on the important stuff, de-emphasize stuff that's irrelevant, don't do zillions of categories of prior medications. Show what you need to show, what the DMC needs to see. Again, there's always this issue of tables versus graphs. Tables can be more compact, graphs may be easier to absorb. These are matters of style, of your own style as a presenter and of the DMC's preference as a DMC. So here's some examples of baseline data. You can see really easy to see pretty quickly. Here's data, cardiovascular medications, easy to see. Adverse events. Are there safety concerns for the subjects participating in the trial? What are the kinds of adverse events that are being experienced? And what about certain categories of events? And here you need to think about the disease you're dealing with and the kind of doctor you have. If you're dealing with, so you need to understand the distinction between serious adverse events, which is a regulatory concept, and grades of events, which the docs use. For oncology, if you present serious, it's often not very useful. They think in terms of grades. So you need to know what your DMC members want to see in terms of adverse events. You want to see, when are the events occurring? Do they occur early in the treatment and then they go away? Or are they recurrent? Or do they not occur for a while and then start to occur? So you need timelines of that. You need to separate signal from noise. The standard approach is to show high-level system organ class, and as Susan said, that's often too broad. And the narrow category, what's it called? A preferred term. I don't like preferred term because they're so much too specific. I like high-level terms, which will put, like, for example, all the heart failures will be put in one category. Regulators don't like high-level terms. They don't know why. And most sponsors don't like them. So when we present data, we do these and high levels and then preferred. There's also these
on that note, and I don't think I'm breaching confidentiality here, we were on a monitoring committee and we were seeing issues in the domain of sepsis and pneumonia. And there were like 40 terms for each. And so we did that. We had the independent statistician go back and create a grouping for us so that we could look at the relationship by intervention group for the sepsis domain and the pneumonia domain. And it was very helpful to us.
Yeah, heart failure is another example like that, because heart failures show up in the cardiovascular system as various kinds of heart failures, but they also show up in the pulmonary system as all kinds of pulmonary diseases. And they're really the same thing. It just depends on how the doctor wrote the words, whether it gets into one system or another. So you
Exactly, Janet. And what you don't know is whether some of these single events show up more than once.
Yes.
So we wanted to know how many unique people had these serious or at least severe sepsis domain events and pneumonia domain events. And we only got that through that grouping.
Right. And it's important to do that for the things that are important. But if you say, I'm going to do that for everything, you'll go nuts.
Agreed.
So here are some examples of the kinds of things that you want to be presenting, but it has to be informed. It has to be informed by, as Tom gave an example, of what you are seeing, of what the docs think are important, if you see something that you think is, I don't understand this, this looks important, call the chair and say, hey, I'm seeing this, is this something important or not? So one thing that's important is if you see a hint of a difference in the serious adverse events, look at the related adverse events, because it could be that the serious adverse events, some of these adverse events are harbingers of something more serious. Look at the severity of the adverse events, the timing of it. But as I said, don't do this for everyone. Do it for the ones that seem worrisome and important. So here's some graphs. You can see quickly, here's two groups. They all have, half of them have an event. This is possibly related to the product. I don't pay any attention to that. And here's what happens to them. So you can see very quickly a sense of what's going on. Here's a table of adverse events from the case report form, where these are event rates, not just adverse events, where in red, remember I said earlier, sometimes color where you want attention to be, we want the DMC to notice them, because otherwise there's just too many numbers. These are events with a rate ratio which doesn't cross the 80% confidence interval. Why 80%? I think if you look at 95% intervals, those are just too wide, I think, if you're trying to find. So some people like to screen data through p-values. I like to screen data through 80% confidence intervals. But again, however you do your screening, if you're going to have tables with lots of numbers, make sure you identify those lines that are important to see. Here's another kinds of graph, AEs, where these are little bar graphs. This is a kind of graph that I actually prefer, where each event, you show the events by frequency, and then you can identify very quickly which events are frequent and which events are different by treatment group. This kind of graph just shows, to me, it's harder to see the frequency. But again, these are all matters of choice. You have to decide what it is you want to show. Here's another one of measure by system organ class, where this is in oncology, and so we use grades and not adverse events, not serious adverse events. Here's another one. I'm just going to show you, these are much easier to read than the tables that I showed you before. Here's a volcano plot. In a volcano plot, these are things where, so here's a risk difference. These are logs of the p-values, and these are things, large sample sizes where you see huge differences in, this is p-value of 0.01, huge differences in certain high-level terms in the treated group. You may want time to the first serious adverse event. In laboratory data, you want to look first to see, is the treatment having the anticipated effect on the targeted lab parameters? That's a clue, if it's not, that your drug isn't working or that your treatment code is wrong. Are there safety concerns as reflected in the lab data? If there are changes in the lab data, do they persist over time? And then always, is there evidence of drug-induced liver injury? There may be 50 different tests performed by the laboratory. The lab data may be analyzed and collected at many visits. You want to present the data in a way that doesn't overwhelm the data monitoring committee. You want to identify potential abnormalities of interest. But again, what's really important is to make sure that you're focused on what the DMC cares about. They'll often tell you, like 3 meetings through, we don't care about these. We don't need to see these anymore, put them in an appendix, but we want to see these. Identify abnormalities in the lab data, as we talked about before. So I'm just giving you some examples. Here's one where you ever below the lower limit of normal, ever above the upper limit of normal. For things like Hy's law, for liver function tests, it's these kinds of graphs, scatter plots, where you identify in here the normal normals. So this is normal at baseline, normal at month 24, and then you see the abnormal values in these different quadrants. You can do, each analyte can have its own page. So here's an example of that. The box plots over time, the number above the limit of normal, the number below the limit of normal, and absolute change from baseline. So you get everything on one page, and DMC this is a Wisconsin graph. You can see this really quickly. I think I talked about that. Here's liver function test. And then these kinds of tests are very useful for liver function. Here's the graph that shows these patients dosed all along like this. And then here's their liver functions. And what you see is at about 2 weeks, it gets abnormal and then it goes back down. So that's not too worrisome. If you saw them up straight, you'd worry. So efficacy, what we all know is that there are, in lots of studies, there are pre-specified ways of declaring overwhelming benefit. I do want to mention 3 cases of, actually 4, but I didn't dare put the 4th one in, so I'll only talk about it. Where the treatment was much, much better than expected, and where there was no pre-specified stopping rules that would have allowed stopping the study. And I would say that traditionally, in my experience, in 40, 30, 20 years ago, treatment effects and sizes were much less than anticipated. You anticipated a big treatment effect and you got a little treatment effect. Recently, there have been trials, there have been drugs that are very, very beneficial. And so the first one that I was involved in was the Lucentis trial, the first phase 3 trials of Lucentis, where it was so, Lucentis is for age-related macular degeneration, and people on the active arm, on the Lucentis, I should say the active eye, on the Lucentis arm were getting, on average, they were improving their vision, and people on the treat and the control were on average losing vision. So it was a huge effect. And the DMC was really, it didn't like, it wanted to stop the study, but it had been told, do not stop the study under any circumstance. So it went to the FDA. It was a snowy day, and the whole DMC and we went with them to the FDA and showed them the data, showed them the report. And the FDA was great. And they said, but don't stop this study. We will expedite the approval, but you don't stop the study because we need to see the safety. So that was an example. I think somebody asked whether you ever go to the FDA. That's an example where we did, where the DMC did. There was a trial, the early trials of nivolumab for various diseases, various cancers. One of the trials stopped early, long before the first look at the data, the first formal look at the data, because the effect was so dramatic that the DMC said, we cannot let this trial go on. And they stopped it for efficacy, and the FDA approved of the drug. And the DAPA study, this just came out very recently. The dapagliflozin for heart failure in patients with and without type 2 diabetes, stopped early, not at a pre-specified look, and the FDA approved it. So there are examples, but you have to be, but to do this, you have to be, the effect has to be really, really huge. And you have to realize it's a big risk to stop a study, to recommend stopping a study in the absence of a pre-specified boundary. Recently, we were involved in a study where the conditional power on the null hypothesis was over 99%, okay? So if the remainder of the study, if there had been no effect, the power was 99%, over 99%. The DMC was unable to continue, stop the trial, and it got approved. So I would say that, and in Nevo, the p-value was tiny for both the target and the non-targeted subgroups. So there are cases when DMCs have recommended stopping a trial without crossing a pre-specified guideline, and the FDA has approved the drug. But the IRS, whoever is doing the analysis, has to know how to analyze the data really well, kick the data really hard, and must have excellent relationships with the DMC.
Janet, one other, if I can take a minute, one other very current example on stopping a trial for benefit is we're about to launch with WHO what could be a 200,000 person COVID vaccine trial. It's called the WHO Solidarity Trial, where we're going to look at maybe 10 to 15 vaccines that are promising. And the primary endpoint in the study is PCR confirmed symptomatic disease. And basically we'll look after every 50 to 100 to 150 events. And it's powered for a 60% protective vaccine to rule out 30% protection. The key is once we hit that boundary, either at the end or partway through, if we hit the boundary for benefit, we will release this result publicly to the sponsor immediately to take regulatory action. But we will continue to follow all participants, even those on the placebo, long-term, because we need to understand the durability of vaccine protection. We need to understand subgroups. We need to understand what the effect is on severe disease. And we need to understand whether there's an enhancement, a negative effect long-term. So people will stay on their vaccine as individuals until there's deployment of that vaccine in their area, then they get access. And so this is going to give us quick regulatory approval, but long-term, much more enhanced insight about efficacy and safety that we're going to be critically important for COVID vaccines.
That's really interesting. I bet you're going to be meeting very frequently.
This with approximately a half a dozen to start up next month, and then up to 10 to 15. This will be as close to continuous DMC meetings as has ever happened.
Yeah, yeah. All right, well, I'm going to skip, I was going to give you some horror stories, so you can look at the horror stories later, but I'm going to give you one horror story that, there's nightmares, so if you want some nightmares, you can read this. But this is about checking the treatment codes. Redundancy is really important. As Delmore Schwartz says, even paranoids have enemies. So here's a story. This is real true story. In fact, every story I told you was true. 3-arm study, control, low dose, high dose. Randomized 1:1:1. We and the data DMC noted some illogical results because the low dose and the high dose, this was for heart failure, were the same for the first 6 months. And then the high dose went higher. But mortality was higher in the low dose than the high dose in that early period. So that didn't make any sense. And the statistician, the young statistician who was working for me said, what should we do? And I didn't know. I said, oh, go away, go check the randomization. It was a way of saying, I don't know what's going on. So they did. And there was a distribution that was surprising. 2599 in the control group, 2534 in the high group, and 2705, and a magic 5.99. Isn't that great? All of us who know chi-squared know that 5.99 is 05. That was what it was. We thought, this is really, it's not impossible. It's you know, it's a p-value, this 05, it could be, but let's look a little further. So we said, well, there's a block size of 6. There are 90 possible ways. So here's, you know, you can play with your combinatorics, 90 possible ways of arranging a block size of 6. We had a master schedule, 3,300 blocks. So you'd expect 36 3/4 copy, 2/3 copies in each block. Well, here's the distribution. And you can see right away that here's the low dose, that the low dose has not only, well, here's the average, right? Here's your expectation. And these don't look like they're following the expectation. And this p-value, the p-value with 90 degrees of freedom was 2.8 times 10 to the minus 74. So that looked significant. That's not like 05. That meant something was wrong. And my takeaway, and what happened was, I think what happened was that these people, there were lots of very small centers. These were these big peaks are those that had the first 2, low were the first 2. And I think what happened was there was a learning effect. And so the people that were the incomplete blocks were overwhelmingly low. And I think that's why they had more deaths. I don't know for sure. But my takeaway from this was it's really important to check the randomization schedule. Most sponsors that we deal with say it's a waste. They don't want to do it. I think that's a mistake. It turned out that in this particular company, which no longer exists, it was a large company, but their randomization schedule for a 1-to-1 randomization was correct. Their randomization schedule for 3 groups had the wrong looping, and that was going on. And there had been many studies before that that had used that program, and nobody had picked up the problem. Probably it didn't matter in most of them because there weren't so many small sites. So in conclusion, these are all things that you should do, but it's important. The ISRG has a crucial role in playing between the sponsor and the data monitoring committee. You've got to understand the drug and disease. You shouldn't be bashful about asking questions, especially of the DMC chair. Everybody needs to trust each other. More than one person at the ISRG should have access to data. And you must ask very carefully. You must have access to all the data because once a trial is stopped, it can't restart. And that's like Susan's once you know something, you can't unknow it. And you need a lot of mutual trust and flexibility. And I'm sorry I went so long.
Fantastic, and a great summary. I will add one quick thing I promised to provide, and there's not time to discuss it, but the example that I was referring to about the randomization code being wrong that was used to generate the DMC reports, you were mentioning that, Janet. There was a fascinating example. We've written it up in the second edition of Ellenberg, Fleming, and Demetz. It's example 2.6 on varenicline in for smoking cessation. Read that. It's fascinating to see exactly what caused the code to be incorrectly used. Fundamentally, there was a drug packaging area that had the correct code, so the study was actually done properly. The randomization was done according to that true code, but there was a separate area called the production area that originally had the correct code, but then there was a dummy randomization code put there in its place in order to run some dummy tables. And when the reports were generated to the DMC, they used the dummy code. And we on 2 occasions said, this doesn't seem right. And the sponsor went back and carefully said, well, you know, we're matching the code, matching the dummy code. And by the way, people are getting what the randomization says, which is the drug packaging code. And they never looked to see that the 2 codes were different.
So what happened? Did the study stop, or did you?
So interestingly, it's a case that, and I'm so appreciative the sponsor let us put this into the book in detail. To be truthful, it was a successful trial where varenicline did show benefits on smoking cessation. There weren't any safety issues that emerged. So we don't look back and say, well, the DMC was completely compromised in what it could do. Fortunately, it was a trial that was positive and didn't have safety issues. And so we kept looking at it saying, this can't be right. And the independent statistician kept coming back telling us, it is, we checked. And what they didn't do was to check to actually align what was reported as the intervention in our reports with what was actually in the vials, or seeing that in fact the drug packaging and the production area codes were different. So it was a fascinating learning experience. And fortunately, it's fairly uncommon. I'll give another example of this, of another setting tomorrow.
All right. Well, thank you all. And I'm looking forward, Tom, to tomorrow.
Well, thanks again to Janet today, and Susan yesterday, and to Katie to make this possible, and to all of you for participating. This has been incredibly enlightening. And yes, we'll gather again tomorrow morning at 8:30 Pacific, 11:30 a.m. Eastern, and talk about, largely for the most part, DMC best practices, and provide a lot more examples to illustrate issues that in part Susan and Janet have already nicely covered, and some additional issues as well. Thanks all.